Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on Prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator.
We have the honor and privilege to have Dr. Matthew Galley. Dr. Matthew Galley is a third-year graduate resident at in the Department of Periodontics and Oral Medicine at the University of Michigan School of Dentistry. He completed his DDS at the University of Toronto in 2019, where he started his own charity initiative aimed at providing gifts for underprivileged teenagers during the holiday season. He was also president of a chapter of the dental fraternity in his senior year. During his BDS and the DDS, he conducted research focused on macrophage polarization and osteoclastogenesis in the context of periodontitis, and has published numerous papers in peer-reviewed journals on these topics, in addition to periodontal clinical research conducted during his residency. Dr. Galley, I interact with a lot of people, and I know that you are going to the top. In a few years' time, I see you guys. You're on your way there. Well, thank you for giving your time today to present on Dental Webinar Series. Thank you so much for joining Dental Webinar Series today. We do have Dr. Pooya Soltanzadeh with us today. He has given us his Sunday morning all the way from the West Coast. He did receive his DDS from Tehran University in Iran, where he practiced general dentistry for 3 years. He spent 2 years as a postdoc and research fellow in Prosthodontics, a post-doctoral program at the UCLA, the School of Dentistry in California. Dr. Pooya was trained in advanced specialty education in prosthodontics at Loma Linda University, from which he earned a certificate and honors for excellent performance in prosthodontics. He received his Master of Science in Prosthodontics, focusing on the accuracy of conventional and 3D printed prostheses. He has published several original articles and book chapters in the field of implant dentistry, fixed and removable prostheses. Dr. Pooya is a diplomat of the American Board of Prosthodontics and a fellow of the American College of Prosthodontics. I think there's a little update now. I know Dr. Pooya is currently working part-time at the Loma Linda University and is into his private practice. Dr. Pooya, thank you so much for joining us once again on Dental Webinar Series.
Okay. So basically today I'm going to talk about like full arch implant prostheses, like it's called like all-on-4 type of restorations or all-on-X. So I would like to talk about consideration in treatment planning for edentulous patients. I'm going to talk about different materials, different designs for full arch restorations. And then if you have time, I'm going to talk about post-op care and then maybe some complications that may arise from like lack of like a proper treatment planning. So all of us like that are there in our private practice, we are dealing with these kind of situations. The patient comes to you like a severe perio disease, all the teeth are hopeless, or like due to like genetics or poor oral hygiene or like negligence or drug abuse or for any kind of reasons, you may encounter these type of like situations that you see in this slide. So what are the options? What are you going to do? Where to start? How to execute the patient, or even how to communicate with the patient? So I would say the first important thing for you is meet the patient's expectation. And the one always says like meet the patient's mind before meet the patient's mouth. Let's see what patients ask for, what the patient wants, what are the expectations, and then based on that, go for your treatment plan and present the case and go through all the diagnosis. So the first thing first is meet the patient's mind. Let's see what the patient wants, you know, and then also explain during your treatment planning or like during explanation of how to do the work. Tell them, okay, this is not a fast forward case. This is not literally a tooth in a day that you see in a lot of commercials. It needs a lot of like pre-measurements, impressions, exams, and also it needs a lot of post-op. It takes multiple appointments, and then these type of like treatments, sometimes like in order from A to Z to finish from extraction to get into a proper prosthesis, a final prosthesis, it may take up to 6 months, 8 months, sometimes a year or year and a half. So they need to know it's not like a quick, fast thing, you know, and it's a big investment for them, and you need to make them sure that you're not going to rush the case for them. And then when they come, you know, like from that terminal end teeth, like poor prognosis teeth, that you can get into these kind of all-on-4 type of cases that the patient love it. And this picture actually is an all-on-6 case on the maxilla. And I took this post-op photo after honestly 6 years, and still teeth are in place, all sharp, no wearing, nothing. And I am presenting you in future slides why the teeth kept like so good. And these teeth actually are CAD-CAM dentures. They're denture teeth. They're not porcelain or zirconia, and they're serving pretty well against like the lower porcelain teeth. So as you know, like for implant supported prostheses, we have different options from removable to fixed restorations. And when you're talking about removable, mostly we're talking about like maybe for lower jaw, maybe 2 implants, ball attachments, locators. And then when we go to more complex treatments, we're talking about bar locators, bar implants, and then we switch into fixed restoration. But you need to know, as we increase the number and the amount of like implants and components, we increase the complexity of the treatment. We are adding more time to the treatment, and actually definitely like it will impose more costs. So all of these things, it should be considered in your treatment planning. It should be discussed with the patient, so the patient should know what's going on. In order to have a successful implant supported prosthesis, you need to consider aesthetics, functions, and one of the more important things at the end is like hygiene. And in order to achieve and meet all these required things for a successful prosthesis, you need to do the right 3D planning. You need to have a good prosthetic design. You need to utilize technology and use the advanced CAD-CAM technology that we have. We use the proper material selection for what you are doing, and then let the patient know about the pros and cons for each material. So as a short pros and cons for fixed or removable, I should say for removable, we have some advantages, including facial lip support. The patient that they have a lot of like relapsed lips or unsupported lips, removable with like flanges can support that and can bring some aesthetics to the profile of the patient. If you have some severe arch discrepancy, like severe class 2, severe class 1, so you can like correct it with removable prosthesis. You can a little like set the teeth off the ridge. You can play around with it, like the size of the teeth and the flanges. You can actually do a little camouflage to hide that discrepancy in patient's mouth. You can improve the hygiene with patients with poor oral hygiene, that they don't care about cleaning the teeth. Maybe a removable option would be a little better, since they can remove the implant, they can remove the prosthesis, they can clean it and put it back on. And also, when you are dealing with removable prosthesis, you have a little more free hand to place the implants where the bone is. You know, it doesn't necessarily have to be dead center in the center of the tooth, or maybe not too much mesial, not too distal. So you have a little more flexibility. And then last but not the least, you save initially a little, like with removable prosthesis. Why I say a little, or when I've written down like as initial cost saving, because literature and experience shows people with with like removable dentures or overdentures, long run, because of like the number of complications or the need for repair, changing housings, relines, the need for loss of retention, and then bring it back the retention to the patient. Long term, sometimes it may be more costly than like a fixed restorations. When you're talking about like all-on-X restorations or fixed restoration, definitely they're all screwed in, so the patient should not worry about like the removable prosthesis can fall out. So retention and security brings some confidence to the patient. The chewing efficiency based on literature can increase 5 to 6 times more. And in long term, it has less maintenance because the number of maintenance is being less, and you don't have to deal with it. So you don't have to deal with a lot of like complications coming from reline or coming from loss of retention whatsoever. However, it has its own challenges, fixed restorations, but if it's done right, if it's planned right, then it would be easier to maintain the prosthesis. So let's talk about like diagnosis and treatment planning, or basically 3D evaluation for that. So we're going to look at the aesthetics, hard and soft tissue evaluation. We're going to look at the restorative space and CBCT analysis to see what are the good options for us to take care of the case. So one of the big things, as I mentioned, was lip and facial scaffolding or support. So patients that they need a lot of lip support, maybe removable would be a better option. We are talking, I'm going to talk about like tissue and prosthetic junction. And during like patient's first visits, you need to determine that marker. You need to decide about incisal edge and maximum smile, should know about it, and also vertical dimension and restorative space. Number 3 and 4 kind of work hand in hand, and number 1 and 2, it gives you an idea about the cosmetic or aesthetics of the restoration. So for example, let's talk about this case. Patient came to my practice, and you see like a patient has a kind of a straight to class 3 profile with unsupported like lower lip, and kind of like, less supportive for the maxillary, for the upper lip. So maybe like offering like a removable denture, just like what you see in this case, can correct the facial profile. Rather than like telling the patient all on 4 would be a great case, you're gonna do like can't like set teeth all too forward and created some anterior AP spread or put AP spread or anterior cantilever. So these may jeopardize the situation. Having said that, this case, because of the severe amount of like bone resorption, even partial would not, all on 4 type of restoration would not be a great choice for her. So that's why like removable would be an ideal case for this. So not all the patients are the good candidate for all on 4. So one of the diagnostic tools that you can do if the patient is a denture wearer, or if you're doing the tooth setup or wax drawing, you can duplicate a denture as you see in this slide. You can cut half of the flange on one side and then keep the flange on the other side, and then take photos and show it to the patient. This is how you're gonna look like if you go to fixed option or with like a removable option. In that case, patient know, and you know with photography and with visual like inspection, that okay, would removable would be good. If I have flanges, are the lips gonna be too full, or they're gonna look very nice and appropriate? And you'll definitely need to get patient's opinion. And many times patients, they have no idea, especially the elderly patients, and then make sure they bring their partner, they bring their spouse, and then get their opinion. And I've had some cases that I delivered a denture and they went home, and then after a week they came back and I said, "Doc, my friends thought my teeth are too big, or I have too much lip support. I loved it, but they say so. Can you fix it?" So luckily for those cases, like I could manage it with just like thinning down the flange or just like a little modification. So I help them to like the prostheses more. But in some bigger cases, like all on 4 type of restorations, you don't have that much flexibility to go back and forth within your treatment. You cannot change it much. The other important thing regarding like treatment planning would be the tissue prosthesis junction. So many of us, even like in our natural teeth, when we are prep the teeth or we want to plan the implants, we ask the patient, okay, smile. But remember, we don't only smile. We have a lot of other lip movements that you need to consider when you're doing the treatment planning. For example, there was a research by Walter et al., actually from Loma Linda 2014, that they looked at the patient's teeth. They evaluated around over 90 patients, and they saw that it's not only about the maximum smile, it's not about only social smile, but we have also different type of smiles. You know, like we have like disgust, we have Duchenne smile, we have like glimpse of disgust, we have different kind of movements, and many of those needs to be it would be different patient by patient. So you need to do photography, you need to do videography, and and look at those kind of movements And if you're about to do some alveolar bone reduction, you need to plan it ahead of time and then take them off, unless like you're going to end up like these cases that I'm showing you in this one. And when patient smiles or social smile doesn't show much, but when she goes to different kind of lip movements, it shows on junction. So remember that it's very, very important. Let's go to the next one. So for example, this patient, actually, this is like a natural smile, but the planning went very, very wrong. So basically you see this CEJ of the teeth, and then that's how the implants are placed. But basically, when you look at in details, you see the implants are placed so low, they should have like do more alveoloplasty, and they place the implants much more higher in order to accommodate the connective tissue, or like the junction for the gum, and then room for the components, room for the metal substructure, and room for the teeth, room for acrylic. So in that case, when the patient smiles, it doesn't show. Not only like cosmetic of it, but also function-wise and hygiene-wise. Now the prosthesis is kind of concave, and there's no way for the patient to clean underneath it. So it ends up like going to pre-mucositis, pre-implantitis, and we end up like a failed treatment plan. And as you see in more retracted lip position, you will see all the threads are exposed, implants are placed too buccally because of like an improper restorative space or insufficient restorative space. We have like chipping, fracture, and a lot of complexity. Everything went wrong in this case. So that's why like All-on-4, it looks easy, and you see it every day on social media, Facebook, this and that. And even like a lot of marketing, dental marketing companies, they get into, because I see it myself on my social media, like a 2 All-on-4 case guaranteed in your practice, this and that. Yes, I mean, you can do that, but it's not that easy. You need to know what you're doing. You have the case, good for you, but make sure you're capable of it, you know your limits, and do it right. So it's not all about like getting your patient, it knows about your ability and your limits too. And I have like turned down some cases, although they were like All-on-4, and I saw like, this is above my practice, it's above my limit, that, hey, I don't want to do too much of All-on-4 for you, like maybe a removable would be a good candidate for you. And the patient just said, no, I want something, please say, sorry, I can't offer that to you, you are not a good candidate. So do not like push for it, do not go for it when you see the case is not a good one. The other thing would be incisal edge. So you need to determine the incisal edge by FNV sounds, and also based on the lip positions and repose position, and make sure the patient is comfortable with pronunciation, with talking. In this case, actually, is a denture case. And this is my first CAD-CAM case that I did like years ago. And when I did it, the patient actually liked it. She was around like 82 years old, and this is her first denture that she could wear it. But I didn't like it at all, and I think cosmetically was terrible. And I had to just readjust it. So I marked it, this is evident denture, CAD-CAM evident denture, and I cut it, did the impression, sent it back, and then the all the way right picture is the final restorations. So why I brought this example for All-on-4 case, because if you, for example, look at the left side picture and you say, okay, this is a good case, the denture is good. Now, based on that, we can place the implants or do the planning, and you will see that you have a lot of room for your components. You have a lot of room for hiding the bar and everything. You do it, and then when the patient goes to the treatment and you finish it, you end up like a very unaesthetic and non-functional restorations that implants and everything is already in. And there's no way to go back unless you remove the implants, you remove the bone, you do the corrective surgery, you do bone graft, and then redo the whole thing. So having said that, it means you need to do proper planning, and everything starts with a proper tooth setup, with proper wax drying, and basically we start with a denture. So you can do the wax drying denture setup with digitally or like conventional way, just like this case. So everything starts with a denture and some removable concepts. Based on that, you can move forward. The first step is the most important step. And based on that, actually the incisal edge of phonetic study to determine the vertical dimension, and then you have an idea about your restorative space. And based on that, if you see, for example, if the teeth look like this, so, and then the bottom of the denture or intaglio surface of the denture to the crest of the ridge is like very tight, then you need to provide room for your components. From there, then you decide about like bone reduction, and then off of that, you place the implant. So wax trim, proper CR relationship and everything is crucial. It determines your VDR, the CR relation. It tells you about the teeth size, lip support, smile line. So this is a very important stage. Do not underestimate it. When you do, this is like a wax drying stage. So when you make sure everything good, then off of that, you go for it. This is another case that this is overdenture and maxilla and all on four on the lower. And this is a little further like toward the end of the treatment, but I just put it to tell you that we keep like trying to make sure everything good before finalizing the prosthesis. And this is the case before and after. He's a young guy, and now you see like here in his 40s, and with changing the restorations, with bringing like more tooth show and modifications on the support, retention, we improve the patient's health, confidence, and phonetics and function. The other important thing during all-on-4 restorations is like evaluating the lower jaw. So lower jaw is important too. You need to know that what are the teeth size and how much you want to show on your lower teeth. As you know, like when we get older, we show less teeth on the upper and then more tooth show on the lower. So you need to have that in your considerations regarding planning. And if the teeth needs to be resized, repositioned, or maybe you need to do some alveoplasty, you need to consider that in your treatment planning. So this gives you kind of general idea how much space is needed. And as you see, for minimal restoration is needed, minimal space is needed for overdenture restorations. And then when we go for bar or bar locators or all-on-4, we need more and more space from implant platform to the proposed occlusal plane. But all these things kind of like under question because we all need to know what kind of material you're going to use, what kind of substructure you're going to use, what kind of teeth size you have, and what kind of like jaw you're dealing with, like class 2, class C, because all these things determines your restorative space. So these numbers are average numbers, gives you a kind of guideline, but in order to do it right, you need to customize it per patient. One way to evaluate the restorative space would be this ruler, or we'll call it massage rulers. If you don't have, don't worry, you can use a tongue blade. So basically, you measure the crest of the, there are two ways to measure it. You can measure a crest of the ridge toward the upper lip, and then you evaluate with a smile or at repose without smile. You can also do that measurement from like the depth of the sulcus from the frenum to the lip at the smile and non-smile position, and then have an idea about like restorative space, tooth show, and this gives you a kind of idea. And then you can also measure from the proposed like occlusal plane. So you need to know to do some photography and ask the patient to talk or smile and see if visually you can see the ridge. If you visually see the ridge, for example, in this case on the right-hand side, you definitely need some bone reduction. And then you go back and look at the CT scan and you see, oh my God, yeah, if I remove that amount of bone, nothing would be left. Then there would be way different options. Either you may go the removable route, or then you're gonna evaluate if you can do some zirconia implants or trigoid implants or more complex treatments. The other way to measure the restorative space is like when you do your tooth setup or the patient has existing denture, you can use a suck down tray or like a clear shield, put it on the articulated and see how much bone reduction is an average needed to be done. You can use a perio probe and make a putty from the denture and then put it on the cast and just kind of give you a rough idea about like the space. You can do some CBCT analysis, CBCT measurements, and you have an idea about like how much needed to be, because these are like less accurate ways, but still applicable in your cases. There's an article like back in 2011 and by CAD-CAM, and they had a kind of 4 categories, and they classifies different kind of options for restorations. So when they are talking about it, when you have more than 15 millimeter of space from the crest of the ridge to the proposed occlusal plane, you can do any kind of restoration. You can do bar attachments whatsoever. But when you are going to 12 to 14 millimeter of space, which is a class 2, locators or overdenture would be perfectly fine. But when it goes lower than that, like class 3, class 4, which is like 9 to 11 millimeter or less than 9 millimeter, definitely in order to accommodate some space, you need to do some alveoloplasty. So let's talk about some CBCT analysis. Why we keep talking about CBCT analysis, which nowadays with like implant planning and implant restoration and the technology is a kind of standard of care. And even whenever you want to do implant surgeries, it's really crucial to have a CT, to have a 3D view over the area. And how we do that, basically, if the patient is a denture wearer, you can put it on and then do the CT to give you an idea. And I will tell you, because denture teeth will not show on CBCT. But it's important for us to do that because it tells us about the bone quality, amount of bone. Do we need some surgery? Do we need bone graft? And if so, how gonna be our future prostheses? And if you do like a digital route, you can actually determine like where would be the emergence profile, where would be the access holes, and what number of implants you can place it. So imagine a patient comes to practice and asks for all-on-4 type of restoration. So, and you have nothing. I mean, you want to do CT. So if the dentures are in good shape, easily you can just put some tin foil over the teeth, like the old ones, like it has some lead in it, because aluminum foil will not work. It doesn't show much. So you can like lay it over like with those lead foil over the teeth, cut off the papilla, so at least you have a kind of outline of the teeth, so you know which teeth you're dealing with. You can secure it with a wax, put it in patient's mouth, and then do your CBCT with it. And this is how it's going to look like when you do the CT scan. If the denture is wobbly, you can do a reline with like some PVS or any kind of material to make sure it's stable in the mouth during the CT, and you have an exact like kind of idea about the location of the teeth, and then based on that, you know which areas like it's good to place the implants. The other way is like, for example, what I did in this case is like when the patient is in wax drying stage, you can put some speedy markers or like some bibs over the teeth, which we need around like 5 to 6 ones at least, with like these staggered different directions, and we do dual scan, which means like we do one scanning of the denture outside the mouth, and then we do one scan with the denture in with those bibs on, and then virtually we can superimpose that and then evaluate the space and the number of the amount of the bone available for those proposed planning. So this is I think you can get it from Amazon or anywhere else, but the initial application of these bibs were in medical fields for radiologists, but now we can use it in dentistry as well. This is another example. So those were stuck on over the existing denture teeth, and benchtop CT was done, and then another CT was done, and then virtually we were able to superimpose those dots together and then have an idea about the bone, the prostheses, and then location of the implants. And based on that, we can exactly tell the patients. Nowadays, I don't promise patients anything regarding like overdenture or fix. I'll do a CT. I take my time. I don't give them the exact answer the same session. Usually I do the second treatment planning with the patient, and I go through, even like show them the CT. I show them the need for number of implants, the bone graft, all those things. And most of the times the patient agree and understand, and we have a much smoother route to go together through the treatment. This is another case that my friends, they did it. So they did the virtual planning, they superimposed the denture over the jawbone, and they decided to do with some all-on-5 or type of restorations, and they did some alveoloplasty reduction guide, and they made the surgical guide and they fabricated that. So, and they needed the reduction guide because the restorative space based on the metal acrylic restoration they wanted to do was tight. So they planned that. And then off of that, they will put the guide to go through the implant placement. The other way of like making surgical guides would be conventionally made or fully guided, as I showed you. But one of the conventional ways is like, especially like this type of technique, I do it whenever I'm using the surgeons and they're gonna do the surgery sometimes, and mostly for immediates. Because what happens sometimes with immediates, if the bone quality is not good or you don't know what happens after tooth extractions, some guides you may not get enough stability or proper one. So many surgeons I work with, or some of them I used to work with, they like the kind of like this type of like guide, which I duplicate the denture off of the tines that I have, and I make it like wearable for the patient, and I open up a window for them and I tell them, okay, this is your window, this is your prosthesis, whatever you want to do, it's better to be done within this window. So place the implants or do your reduction and everything within this window. And if you see in the lower right picture, you will see that I have some markings over the teeth, and I told my surgeon that, okay, these are the places that I like have my implants. So if you can do and accommodate the implants in those areas, that would be perfect for me. And as you know, guided surgery nowadays, I'm sure like you've heard a lot of lectures about it, so I'm not gonna go to the details of it, but there are a lot of ways to do that. Different softwares, different companies offer that, but make sure if the companies and technicians, they do that for you, definitely reevaluate it. Do not like say, okay, I approve it, you're more experienced. No, you are a clinician, you are a dentist, and you need to know, proofread the planning. Sometimes they don't know, and then they put it too buccal, too lingual, because many times they look at it only as like parallelism, and they don't look at it for the proper distribution. They don't look at it like as details as a clinician. So you need to make sure you look at it from different angles. Just like this case that we did some surgical guide, we made a surgical guide with some pin secured there, and then oral surgeon, they drill through it, like, and then they raise the flap and they place the implant freehand, although through the guide, and they sutured it, and the patient is happy. Let's talk about the materials now. So there are different materials. It can be metal acrylic. We call it fixed complete denture or hybrid prosthesis. The other option would be metal ceramics, that basically we can have it segmented or connected. When we're talking about segmented, basically it means like we are doing like 3 or 4 bridges, 4 implant supported bridges in the mouth. Or you can do the same thing with zirconia. It can be segmented or it can be connected. So metal ceramic and zirconia, and honestly nowadays I do mostly zirconia, and it's a strong material, aesthetic material, and if you can do zirconia, multiple zirconia bridges, that would be perfect. And the advantage of these things would be they may need less bone reduction, they're more aesthetics, less complications, so over metal acrylic. There are a bunch of studies talking about metal acrylic, plaque retention, chipping, complications. So that's why many people, they have switched over to zirconia restorations. Nothing wrong with metal acrylic, like overall as a treatment, but you need to know where to place it, how to place it, and you need to look at the patient hygiene as well. So we like these complete dentures because they can securely screw to the implants. The patient is not worrying about like removing it, placing it, clean it, and they create a good amount of function and chewing efficiency. Aesthetically, they're pretty, and compared to like zirconia or the metal ceramic one, is still like a little cheaper than that. How much space we need to have for metal acrylic restorations? It's around like 15 to 20 millimeters from implant platform to the occlusal plane, to the proposed occlusal plane. And that space needed because we need some space for the abutment and around 2 to 3 millimeters for the connective tissue. We need around like 4 millimeters for the substructure, for the bar. We need around like at least 2 to 3 millimeters of acrylic all around the bar. And you need some thickness for the tooth. And if you add these numbers, you will get to the same numbers. And if you don't do so, then you may end up like in a restoration on the right-hand side that your prosthesis looks, and from inside or integrally looks like concave. Patient smiles and shows the junction of the prosthesis to the bone or to the gum. It's not hygienic, and in the long run, the patient gets preimplantitis, complications, pain, discomfort, and a lot of things can happen. So it's important to have good amount of space. Your prosthesis should look like convex from inside the area, just like a hygienic pontic area. So how many implants should be placed? That's also another thing you need to know. We all talk about all-on-4, but now there are different literature and discussions talking about all-on-4, all-on-5, all-on-6, but minimum is all-on-4. It's doable, definitely. But when you're dealing with a very resorb ridge, when you're dealing with a poor quality maxillary bone, when you're dealing with an improper implant distribution, maybe it's better to add more implant to your treatment plan. And you need to know, based on the different literature, we have around like 10% of implant loss in maxillary fixed dentures. So these numbers coming from like conventional dentures. I have not added literature about like the Zirconia implants or pterygoid implants, because for those, many times we just do 4, and those implants, they most of the time they provide way more anchorage and bone integration and rigidity. So maybe in future we will talk about it, but this is for conventional implants, like regular sized implants in maxilla. For mandible, the same consensus. However, because of the bone quality, they have seen like even they have less complication and less implant failure, which is around 3%, almost a third of like what you see in maxilla. And again, they look at it, if you do more, it depends on your opposing dentition, it depends on the bone quality, it depends on what's the patient hygiene and function and anatomy. So the recent literature, 2009 and 2018, they talk about 6 is a good number of implants if you want to have a good success and survival rate. And if you go 5 for both jaws, then it would be sufficient enough to make sure that you're going to have a successful treatment. So the new consensus is not only about talking all-on-4, basically talk about all-on-5 or all-on-6. The other thing that we need to know about implant planning for all-on-4 type of restoration is like AP spread, anterior posterior spread, which basically talks about like a cantilever in all-on-4. You know, they talk about it if you have a space, if you have an imaginary line from the center of the most front teeth to the distal of like the back teeth, you should not extend too much posteriorly. So they talk about maxilla, and if, for example, that AP spread for maxilla is 15, you can extend it another 15. So 1-to-1 ratio would be perfect for maxilla. And for mandible, you can go a little further back, 1.5 to 2 times, because of the bone quality is more solid, is more type 3, type 4. So implants, they have more support, more rigidity around them. However, like if you have opposing natural dentition or opposing like denture, it changed the equation. So if you're dealing with opposing an overdenture or a denture, you may have a little more AP spread. You may have a little, give you a little more hand to have more cantilever. But if you're dealing with natural dentition, you don't want to go further back because it increases the chance of fracture. One of the recent studies in 2012 published in iJomi, they talk about cantilever or not, and they looked at different studies. Based on 19 of them, they saw that still cantilever might be a good option it has higher amount of failure and higher risk. However, it's not very significant. So it comes to the clinician judgment. It comes to the case-by-case evaluation. So when you're dealing with a natural dentition maxilla, and then an older lady, and you want to do all-on-4 type of restoration in the mandible, maybe you can extend a little more, and you can have a little more AP spread for that. Why cantilever is important? Because when you have forces all the way to the distal of the restoration, then you have compressive force on the most posterior teeth and like tensile forces on that, and increase tension, and in long term it may increase the amount of like load and failure to the implants. And if it adds to some improper or insufficient hygiene, then will be catastrophic. So how to reduce these stresses? You can use tilted implants, or you can use wider implants. So in that case, you can actually distribute the forces better. Tilted implants, they're advantageous because they're usually longer. They provide more bone integration. You can avoid some anatomical like landmarks, or including sinus or nerve. And there's some studies actually, they show that you regain some bone on the distal of the tilted implants. So the tilted implants actually are viable options, and then you can correct the angle of them with a multi-unit, as you see in this picture, and then you make them parallel. When we're talking about AP spread or anterior posterior, it's not only like in the posterior, but also in the anterior. You need to make sure you don't have too much of a cantilever. Just like this case that I did the treatment with zirconia. The patient is a big young guy, and it's a severe class 3. So and the surgeon placed the implant. I had no option rather than like doing the restorations. So that's how the final process came out. And when I deliver it, it was important for me to have a good distribution and good occlusion, because occlusion matters. I don't want too much forces. So when I delivered the case, basically I tried to have like edge to edge type of occlusion. I tried to maintain like group function occlusion on each side, working and non-working side. I tried not to have too much of like heavy contacts in the anteriors. And I recommended the patient to wear night guard. So this is the thing that you need to plan ahead of time. And knock on wood, so far it's been doing okay. And that's the max I could have done for this patient. Sometimes if you're dealing with these kind of cases, you plan for all-on-4, you send it and you get back the implants and you do impressions. It looks like this. What are you going to do? And the patient in this case has opposing natural dentition. So you have no other option rather than switching to bar over denture, because in that case you can control, you can get some tissue support, and you can control the forces, distribute the forces between hard tissue and soft tissue, or basically on the bar and the soft tissue. So you can have a better success in these type of treatments. There are different kinds of like all-on-4 restorations. You can go over implant level or abutment level. Then we are talking about implant level, everything directly goes to the implant. But when we're talking about abutment level, we're going to have a multi-unit, and then on top of that we have a smaller screw, and then we connect the prosthesis over that. Which one is better, which one is worse? We usually like abutment level better, because it can correct the angulation of the implant. With these kind of multi-units, it's easier for us to remove the prosthesis, because as soon as you remove the prosthesis from the implant or remove the healing abutment, the gum tissue will collapse. And then when you want to put it back on, it's kind of torture for the patient. So you don't want to deal with those, and you don't want the patient hit you and have a very like unpleasant like experience in your practice. So multi-units kind of preferred. And on the other hand, if you have any screw loosening or fracture, it usually goes to the weaker part, which is the smaller screws, and retrieving those kind of screws is much easier than dealing with retrieving these screws with higher torque in the implant system. And it comes with different cuffs, different like gingival height tissue, which makes it above the gum level, so you can visually see. For restoration, for planning, for cleaning, everything is much comfortable for you. These are the things that I mentioned to you. Yeah, easier maintenance for you. Sometimes we do abutment level when the implants are placed a little shallow. The advantage is like it's sometimes less component needed, and also when you have a tight space and a very tight restorative space, maybe you go through the implant level restorations. I had this case done, and basically in one area, the alveoplasty was not done, and I didn't have enough restorative space. So just in one implant, I did implant level, and the rest that I had enough space, I went for abutment level. So you can sometimes mix and match. And let's talk about the metal frameworks. There are different kinds of design, different kind of implant platform, framework designs. But when you look at the literature, you have to make sure that the framework, the impression stage should be very accurate, and the framework should be passively fit. If it doesn't passively fit, you impose and you open the door for implantitis, tensions, and implant failure and complications. So make sure everything is passively fit, and you don't want these type of things in your x-rays, because micro movements creates peri-implantitis, attracts the inflammatory cells, and long-term you may have issues with your implants and with the tissue surrounding that. And if you're lucky, you may just have the screw fracture in those cases. Impressions, as I mentioned, is important. We have different kinds of impression, open tray, closed tray, but make sure for these kind of restorations, we would like conventionally to do open tray, and we would like to split all the impression copings together. Just like this case, you can do like initially do closed tray impression, send it to the lab, or you yourself make a kind of jig and then reconnect them in patient's mouth, like this case that I did. You can also use like some GC pattern and connect them together, but remember this cannot be in one session because the GC still shrinks for 24 hours. So you need to connect them, cut them, and then later to reconnect them again. And the other alternative would be just use your burn burrs or some small wires and then connect them together. Nowadays, I've seen like there are different companies that are making some like thicker wires that you can connect to the implants and then secure them with some composite or any kind of material, and then directly do your impression for the patient. And then we always use the PVS or polyvinyl siloxane or polyether and some proper border molding. And then we would like to verify the impression by putting verification jig. However, if you really confident about that, you may skip that session. I always tell the patient impressions for all-on-4 or all-on-X kind of restoration, it may be 2 to 3 sessions. I gave them an idea and I lower their expectations so they don't think it's just one impression and next time like they will have their prosthesis. Now that we are into digital world, this is a courtesy to Dr. Bedrosian. This is one example. I actually got it from his Instagram. I haven't done fully digital impression just like this, so I borrowed this case from him. So basically, you put the impression, impression copings or in the patient's mouth or scan bodies, and then you scan it, and then you make the PMMA, or you can send it to the lab. They mail you the framework and you make sure this passive fit, you try it in, and then from there you can finalize your restorations. And if you notice, there's some like dots in the palette, and this helps for the scanning, for the stitching of the images, and for better accuracy of your scan. Another conventional way for teeth setup and the bar position is like you conventionally set the teeth, and based on that, the lab will make sure the bars is within the confinement of your prosthesis. Usually, you can also do some conventional ways too. Then, based on your implant position, your tooth setup, lab can make you a kind of pattern resin planning with like some temporary abutments. And you try it in patient mouth, with everything good, you can send it to the company. They scan that GC pattern in the middle prosthesis, the middle like a triangle, and then they mill exactly what you asked for them. And in this case, because I did the second molars in metal, that's why I did it. So I did some wax up on the second molars to make sure I have a good occlusion, and then they mill the framework, and I delivered the case just like that, and I reset the conventional teeth over that area. This is the CAD-CAM prostheses and CAD-CAM frameworks that we can do. So everything nowadays would be digital. Here it shows how the space is tight for the bar, and then the patient will feel a kind of bump in the lingual of the teeth. This is not what we want. And this is done because we didn't have enough bone reduction, we didn't have a proper planning. There are different kinds of bar designs, but based on the literature and mechanical studies, we would like have I-beam or L-shaped beam because of the strength and because they have enough room for us to set the teeth for them. When you are dealing with tight space, then you have no other options rather than metal ceramics or zirconia restorations. You need to make sure when the space is limited, you need to do that. And also with patients with like a very high amount of lip movements or very high demanding patients or high aesthetic cases, maybe zirconia or metal ceramic would be a better option rather than metal acrylic ones. The amount of space that we need around like 8 to 12 millimeter minimum. And again, because we need like certain amount of thickness for your biologic width or connective tissue, for substructure, and the porcelain or zirconia thickness all around it. And you need to know your limitations. So this is the case that one of my friends in Loma Linda did it, Dr. Al-Karni, and the implants were already placed. He just did the restorations, and then they decided for fixed restoration. So they did the implant impression, open tray, splinted. They did the wax up over it. They milled the PMMA restorations. Patient was wearing it for a while. They scanned again and superimposed it, and based on that, they milled the metal framework, and they did the porcelain. They did the bisque drying, and they make sure they did the adjustments and make sure everything good, and then they finalized the glaze layer, and they made them final prosthesis just like this one. And patient is like a very big guy, very like strong masseter and very strong like chewing forces. That's why they decided to go, and for sure the patient had enough money, so they decided to go with metal ceramics. So sorry, ladies and gentlemen, hopefully I'm not going too fast. I'm just trying to finish the presentation within an hour-ish or an hour or something. So if you have any questions, let me know. And always, like when you're doing like such big cases, it's always good to deliver a kind of night guard and make the patient night guard to wear it at night to avoid chipping, complications, or excessive force to your prosthesis or your implant components. Unless like this is a case that came to my practice, the case was done in Australia, patient wanted to get like a new pairs of prostheses, and you can see it's all porcelain, and patient is not wearing any night guards. Implants are kind of placed a little buckly, and material selection was wrong and everything, and basically the patient chipped all the teeth almost, you know, like you can see. And definitely restorative space was very tight. This patient was relatively young. He was in late 40s, I think, and it's not something you want to see. Zirconia is another option as one of our favorite material nowadays. And why we like it? Because it has some advantages. Zirconia overall comes in different phases: monoclinic, cubic, and tetragonal. Tetragonal is the most stable and strongest phase. And when they add some cubic phase to the tetragonal, it becomes more translucent, more aesthetic. So not all the zirconias are the same. Different companies, they make different zirconia because they play with like material, the cerium and yttrium, and they make different kind of zirconia. So make sure whenever you're doing with any cases, even single crown bridges or all-on-4, make sure that your lab utilizes a good brand, a good zirconia that has some research or study and some good experience with them. You know, do not like buy any cheap zirconia, or like if the lab says like, oh, I can make it very cheap for you. So I'll be a little doubtful with that. Use the best material for your case. We like zirconia because it's very strong based on studies and all the tests, even like stronger than like titanium alloys. It's very, very resistant, and make sure that when the lab makes the zirconia crowns, they're highly polished. And then if there's a glaze layer, they put glaze on top of the polished surface, because the polished surface after a while like goes away after a few years, and then the zirconia get exposed. And if it's rough and it's not polished, it's going to be actually more abrasive. Plaque adhesion is pretty low compared to many other material, compared to Emax and other PMA or any kind of acrylics. So we like zirconia. It has some transformation toughening, which means like if you have a small cracks, there are some monoclinic phases that goes around the crack and limit the crack propagation. And in that case, they call it like a self-healing or smart zirconia because it doesn't let the fracture goes away. However, if you have like severe cracks or external flaws, this can still happen. So in general, we like to have zirconia restorations opposing a kind of, if you're doing both arches, to metal acrylic, because many cases that we've seen when we both do zirconia arches opposing each other, the patient have a lot of clicking unless they don't care. That, and also the other thing, apart from clicking, is like when you do one arch zirconia, one arch PMMA, if you are about to have some complications, you usually have complications on the weaker arch, which is going to be your metal acrylic rather than your zirconia. So it's actually maintenance-wise is much easier for you and for the patient. So basically, they call it, you can have a controlled failure. So this is another case that my friend Dr. Soltanzadeh did, and as you see, it looks very decent and very aesthetic for the patient. So maxillary zirconia and mandibular VP metal acrylic. We always, for zirconia, we would like to have a prototype, which is like a full arch PMMA, just like one step before fabricating zirconia restorations. Patient will wear it for around a month or two to make sure they like the aesthetics, function, and also you do your adjustments, occlusal adjustments on the prototype. When that time goes, then you will scan that or send it to the lab, and the lab will scan it and then mill the final zirconia off of what your adjustment. So when you deliver your zirconia restoration, you have minimal adjustment needed. The embrasures for zirconia, you have to make sure, and the lab should know that when you do it, you have to make sure it's round and it have enough thickness, unless you're going to deal with fracture. If you want to, aesthetically, you have some obligations regarding the embrasures, you can reinforce them lingually. So in that case, you will be able to have a good strength, so the zirconia bridge will not fracture. When you make embrasures or the lab makes the embrasures, you have to make sure you have enough certain numbers. You need to have around 9 millimeter of like space from the implant platform to the occlusal plane, and the connector size should be around 9 to 12 square millimeter. And in that case, you make sure you don't want to break. Embrasures should be made round, not sharp, because that create like external flaws. And although you have transformation toughening, still there's a chance to fracture. Designing of like the zirconia, nowadays many people, they use translucent zirconia, nothing wrong with it, it's pretty good. But if you want to do really, really high-end full arch zirconia, you can layer it with some porcelain. Make sure if you want to do that, do the design in a way that the incisal edge or occlusal plane are still in zirconia, and you only for cosmetic reason do the porcelain on the buccal surface of the restoration, so they don't chip. Also, the lab should use a porcelain specific for zirconia, and they do this the slow cooling system. So in that case, the porcelain shrinks and then cools down, so everything would be perfect, and then minimal amount of like the veneer and the porcelain. Basically, whenever we are dealing with cosmetic cases or we want to do layer porcelain, we usually do K9 to K9. We don't go and then do porcelain stacking on the premolars or molars, unless like the patient is really insisting on that, or really have high smile line. So just like this case, and as you see, you can do the designing, and then they make the incisal edges over zirconia, and they can do some internal staining, and the case comes like that, and the lab will put the porcelain. So basically, it has some cutbacks, and they create room for facial veneering. And as you see, like the lower jaw is just like a CAD-CAM denture, and the strong is nicely done, and everything is good. Connector size, if you do metal ceramic or zirconia, you need to know your thicknesses, and you need to know the dimensions. Then list amount of like connector size comes for gold, and then metal ceramics, and then for lithium disilicate, you need to have like really thick connectors. And these rules applies to actually natural teeth as well. And for zirconia, you need to have at least 4 by 3 millimeter. And there's some lab technicians, they actually like it even more than that because of their experience that happened. But literature suppose like 12 square millimeter would be the best one. You need to have a good amount of like keratinized tissue around your implant. If not, you may consider tissue grafting, because when you don't have a good attached keratinized tissue, you have high chance of premucositis, preimplantitis, inflammation, and then long-term complications around underneath your prosthesis. If the implants, because nowadays everyone talk about all-on-4 and immediate loading, if you don't have a good stability, it's better not to load the implants, just wait. And during that phase, if you want to give the patient denture, make sure you reline it with a soft reline, and make sure you have at least more than 3 millimeters of soft reline, and then change them every like at least 1 month to have like a good cushioning effect around your implants. You don't put too much pressure on the healing phase. After after 2 months, you have a good amount of like, you expect a good amount of osseointegrations to make go back to load the implants or so, but you don't want to deal with the complications or like loading the implants within first months of the implant placement because of the lower stability. Design-wise, when we are designing for maxilla, we would like a good contact over the ridge. This is a case that I did second molars in metal, so that helped a lot to protect the teeth from wearing off from other teeth. You need to make sure you have a highly polished surface. For maxilla, because in case we get space by resorption of the ridge between the maxillary prosthesis and the ridge, then there would be a space, so you have some phonetic issues, air pass through. But for mandible, that we are not dealing with it, you can still have a highly polished metal on the interior surface of the prosthesis. If you don't have enough space, just like lower right picture, you will see the patient will deal with a lot of complications. So we would like a convex interior surface, and you need some compression on the tissue. So make sure that you educate the patient regarding cleansability, and then it's cleansable for you. When you're doing a zirconia restoration for maxilla or mandible, doesn't matter, you have to make sure those areas that touching the gum, they should be highly polished surface. You don't want to put too much stain or glaze layer because they attract plaque and they are not very hygienic. This is how we will come up with the other view. For mandible, it's a different story. I prefer to have a like L-shaped design or L-beam design. You would like to have like highly polished metal, so it gets less plaque attraction, convex profile, and it's cleansable. In that, and then lower right picture, and it's one of the cases from Dr. Goodacre's ebook that he actually designed some like tunnels or grooves between the implants. So basically, it helps for the patient to guide the floss or guide the single tough brushes to go in between and clean the implant areas much better. And for the mandible, we kind of like high water design, which means like we need around 1.5 to 2 millimeters space, so you don't get hypertrophic or granulation tissue going around because of lack of hygiene. So they call it high water design. All right, so that's all. I was successful to finish the lecture almost within an hour. Again, like happy St. Patrick's Day, and then happy Nowruz to all people around the world. Hope you enjoyed the lecture. Sorry, I went through fast a lot, but I tried to accommodate and address a lot of issues regarding treatment planning and all of those that. Okay, I'm open to any questions. Thank you for listening, and thanks for your attention.
All right, thank you so much. Thank you so much, Doctor. We do have a question here. Daniel, are you there? Daniel, can you hear me? If you can hear me, you're able to speak. Just unmute your mic and ask your question. Anyway, I'm just going to, okay, so his mic doesn't work. Okay, he said, what is your preferred hygiene maintenance protocol for fixed full arch?
So based on the literature, we look at it every 6 months to a year. And also ideally, we would like to see the patients just like regular patients every 6 months to come to your practice, let the hygienist know about the cleaning protocol, educate them, because some of hygienists, they don't deal with like all-on-4 cases, so it's better to show them and educate them to go around the implants, remove any calculus, any inflammations, and monitor that. And it doesn't necessarily have to, we don't have to remove the prostheses every time they come. We just need to make sure that we can access around the implant periphery of those areas and then get them cleaned.
Okay. And I know you talked about the verification, that if you're sure you did a good impression in terms of that you joined it with raising GC pattern raising, right? You don't have to go back and do a verification step. Is that what you said?
Well, honestly, I never use GC pattern. I usually use composites. So I usually use old burrs, like the burnt burrs. I keep them and I connect the implants together and I joint them with composite. In that case, many times I don't need verification jig, because as soon as you remove them and you splint them, you can put it back on and make sure everything is passive. And I do that. GC pattern, the shrinkage continues up to 24 hours. And you don't want that.
Okay. Can you describe what the composites type that you do? So you use old burrs, you said?
I use, you see, like let me open this up. So different ways. One way if you do a 2-session impression, you do close-tray impression, just like put the impression copies over the implants.
Okay, without joining.
Yes. Well, you just like do a regular impression. You pour it up. Now you have the implant area on your cast. Then you can use triad material or like tray material. You do it and then you cut them. Okay, the lab does it usually for you, but if you want to do it yourself, so you cut them just like in this picture, and then patient comes back in second appointment of the impression, and you put them on, and then you connect them with packable composite.
Okay.
The other way, just like this case. The other way is you can also make the composite like roll it in patient's mouth, like, and connect and put it over the impression copings, cure them, cut them intraorally, and then reconnect them again with a composite. Okay. So basically you do your both appointments in one appointment. It takes a little longer, but you can cut them, reconnect them together to make sure there's no shrinkage happening. This is the conventional way to use like GC pattern. So you put it in patient's mouth, you cut them and reconnect them again. And this is the one that I usually do, is I put any thick wire or like the shank of the burrs. I put them and I hold them between the impression copings and I connect them with packable or flowable composite. And when I make sure this is all rigid, solid, and it's strong, then I do my impression over it.
Okay, nice. So if the patient has like you also mentioned about a high smile line. Yes. I don't know if you want to go. So if the patient has a high smile line, so obviously the transition zone will be visible, right? So you're thinking towards getting the patient a removable that has a flange that covers that. Would that be if reduction is not an option? Well,
case by case is different. You need to meet the patient's expectation too. In some cases, you may end up like literally removing the implants too. Especially in this case, we had a lot of like implant situation issues. But yeah, in some cases, we turn into a removable. And in some cases, what we can do is just rather than like a metal acrylic or something, we switch into zirconia or metal ceramic restorations, all-on-4 type of restoration. So you can make them a little more aesthetic, and then you don't need that much of pink showing. So, and you elongate the teeth.
Okay.
Healing Hands Health Society presents Dental Webinar Series. we have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries,